Osteoarthritis is the most common form of arthritis and affects millions of individuals. It is classified as mild, moderate to severe. It affects many parts of the body, including the knee. The knee joint is made up of the femur, tibia, patella, along with the synovial membrane, which contains synovial fluid. Synovial fluid acts as a lubricant in the knee joint. The end of the femur is covered in articular cartilage, which moves against the articular cartilage of the tibia. In a healthy knee, the articular cartilage is smooth, without fissuring, and the bone is smooth. The synovial fluid is viscous, aiding in lubrication. The knee can move through its range of motion without pain. Over time, osteoarthritis affects the bone, cartilage, and synovial fluid of the knee. With mild knee osteoarthritis, you will begin to have discomfort in the knee joint. Though the joint space appears normal, the cartilage matrix has begun to break down from a combination of wear and tear and increased production of degrading enzymes. In addition, bone spurs, known as osteophytes, may begin to develop on the edge of the joint. These small, smooth, dense growths of bone are part of the body's natural response to the loss of cartilage. Progression of the disease may be slowed at this stage by increased exercise and weight loss. With moderate knee OA, changes in the joint are much more evident. The cartilage surface between the bones has begun to erode, narrowing the gap between the femur and the tibia. Hyaluronic acid, which helps synovial fluid lubricate the joint, is now becoming less viscous, elastic, and concentrated. Osteoarthritis often affects the subchondral bone, located just underneath the cartilage. Subchondral bone provides hydration and oxygen to the cartilage. As subchondral bone flattens and tries to repair itself, cytokines and proteins are released into the synovial fluid. Osteophytes may increase in number and size, making the bone rougher. All these factors combine to make joint pain more severe and long-lasting, both with movement and at rest. Weight loss and exercise, pain relievers, HA, or steroid injections are commonly prescribed treatments. With severe OA, conditions worsen dramatically. The joint space has become far narrower, causing more rapid and severe destruction of the cartilage. The knee becomes inflamed and sore. Synovial fluid is decreased, increasing friction and pain during movement. Within the synovial membrane, destructive proteins are produced which further degrade cartilage and soft tissue around the knee. Osteophytes continue to develop. Bone moves against bone, not cartilage. Mobility, activities of daily living, and quality of life are severely impacted. Treatment for severe OA is typically surgery by receiving a partial or total knee replacement. If you are suffering from knee osteoarthritis, speak to your physician to discuss treatment options.
The knee joint is the largest joint in the body with an extensive network of ligaments and muscles. Body movements depend on the knee for support and stability. The four major bones that comprise the knee joint are the femur, tibia, fibula, and patella. The knee is held together by a joint capsule and ligaments. It is a hinged joint, allowing for flexion, extension, and very slight rotation. The patella, or kneecap, is enveloped in the quadriceps tendon to give greater mechanical advantage to the extension of the knee. Four major ligaments connect the tibia and femur: the lateral collateral ligament, or LCL, and the medial collateral ligament, or MCL, which are parallel to each other. The anterior cruciate ligament, or ACL, and posterior cruciate ligament, or PCL, cross over one another in the joint cavity. The ligaments restrict anterior and posterior movement of the tibia on the femur and aid in controlling rotation and joint stability. An ACL tear may occur because of a blow to the knee or in a situation that places the knee in a combined position of flexion and internal rotation, of valgus or outward force, and external rotation of the tibia. The classic sign of an injury is the athlete report of hearing or feeling a pop. This is immediately followed by swelling of the knee. For valid results in the field, medical personnel must examine the knee quickly before swelling occurs to determine if there may be an ACL tear. Follow-up diagnosis is with an MRI. Treatment includes surgery followed by physical therapy.
Immersion media, next-generation training and instructional media. Years ago, a torn ACL was a career-ending injury for an elite athlete. With advances in technology, surgical procedures, and rehabilitation, however, an elite athlete now has an excellent chance of returning to high-quality sports participation. To keep the joint stable, a set of 4 ligaments keeps the knee in a hinge-like position while you move. 2 ligaments on either side of your knee joint, the medial and lateral collateral ligaments, connect to either side of your femur and tibia and limit shifting movement left or right. The other 2 ligaments, the anterior and posterior cruciate ligaments, connect from the base of your femur to the top of your tibia. They cross each other and prevent the knee from excessive forward and backward movement, as well as twisting movement in either direction. If a movement is forceful enough, any of these ligaments may snap, including the ACL. Once torn, the ACL cannot regenerate or repair itself. The ACL reconstruction operation is now typically a 1-hour outpatient procedure, performed successfully more than one way. We'll examine one of the more common methods used in ACL reconstruction. The entire surgery is completed through just a few tiny incisions. One is made for the insertion of a tiny camera and to deliver fluid to establish a clear view of your joint. 1 or 2 additional incisions are made on either side of your kneecap to give the surgeon access to your joint. 1 very small incision is made to anchor the new grafted ACL in place. To start the procedure, the surgeon will insert a probe to inspect the damaged joint. A small motorized shaver will then be used to remove the damaged ACL and prepare the area for the new one. In every case, a surgeon will also inspect the entire joint to determine whether there is additional damage warranting other repairs. Then, the surgeon will use a device called a retro-flip cutter to create a tunnel through the femur and into the knee joint. The surgeon will also create a tunnel through the tibia and into the knee joint from below. These 2 tunnels become the source of the anchor points for the ACL graft. In most cases, the surgeon will harvest a portion of your own hamstring tendon to use as the graft. Using your own tissue reduces the likelihood of your ACL rupturing again, and is a reason some surgeons decide not to use a tendon harvested from a cadaver. A surgeon will harvest more hamstring than needed to avoid the challenge of not harvesting enough. To the patient's benefit, hamstring tendons consistently regenerate over time as well. Your surgeon will prepare the harvested hamstring and pull it through the upper hole and into the lower hole just taut enough to mimic your original ACL. A small grappling hook will anchor the upper end of the graft, and a screw will stabilize the lower end. The screw is usually bioabsorbable, meaning your body will incorporate it into the bone over time. The graft from your hamstring tendon will act as a scaffold upon which a new ACL will grow. Over time, the hamstring graft undergoes changes and is strengthened, leaving a strong, viable ACL.